Thank you very much, Jason, for that wonderful introduction. And thank you, everyone, for joining me today, taking time out of your day to hear a little bit about some universal assessment challenges. And I have collected these as I've worked with different schools over the past years. I have consulted with schools of osteopathic, allopathic, dental, chiropractic, podiatric, nursing, and pharmacy schools. So that's when I came into the medical education arena. I will say I'm not originally from there. My PhD is in higher education administration. Found myself in the healthcare-related fields and am very interested in the what we're able to do with this tool of ExamSoft in order to evaluate student learning outcomes. So let me begin by sharing with you the agenda for today. I'd like to talk a little bit about establishing the context for why we're doing this, the internal and the external drivers that motivated us to take this path in assessment. And then talk a little bit about how we capture the data that we would like to use, and we do it via a process we call coding. I'd like to share some exam blueprinting strategies that we use to collect information about our curriculum coverage, and discuss effective use of data in this wonderful world of learning analytics. So looking at the external drivers, doing some reading across the various medical and healthcare fields, the accreditation standards are universally calling for more documented assessment data. They're looking for greater accountability for assessment practices. Right now, I'm actually chairing two self-studies, one for a pharmacy school and one for Middle States accreditation, and they're remarkably similar. The pressure on the federal government to the accrediting bodies to demonstrate that they're showing students are learning, that students are improving, that there is a change that happens as a result of having attended a program or participated in a higher education program. And that pressure for data and for evidence-based change is only increasing over time. Some people say, oh, is this, focus on assessment a fad? I really don't think so. I think it's with us to stay. Here's an example from the basic World Federation Medical Education standards. They've recently updated their standards, and it called for strengthening the requirements for alignment between teaching and learning. It used to be you can just say, okay, this is what we're teaching. Now much more of a focus on, that's what you're teaching, that's great, but demonstrate what's being learned. There is an increased attention to formative assessments with provisions to provide, for feedback. Student feedback needs to be frequent and early. Also, there's an increased emphasis on assurance that the graduate outcomes are being assessed. And I am quoting here Hayes from 2014, the impact of the revision of basic World Federation Medical Education standards. Looking at another set of standards, I think I passed those up. Oh, the standards for accreditation for medical education programs leading to the MD degree, you're going to find a parallel thing happening. Standard 8.2 requires uses formally adopted medical education program objectives. They want clearly articulated objectives, and that you have a variety of outcome data from those objectives, that the school or college employs a variety of measures for the assessment of student achievement. And 9.7 calls for ensuring that each medical student is assessed and provided with formative feedback to allow for sufficient time for remediation. And we're going to spend a lot of time talking about that particular requirement. So some of the internal drivers, those are the external. Certainly we know that the accrediting agencies are very big drivers, but quite frankly, it's not what drives me. I think if we do the right things internally, we will satisfy the external accreditors. It should be about opportunity and not so much compliance with regulations. We all want to do what's right for our students. So from the student perspective, almost everyone I've talked to puts this right at the top of their list of wanting to identify student weaknesses early, to remediate early. In the case of a pharmacy school with a 3-year program, maybe the first 3 programs are primarily didactic. If the weaknesses are found there before the students go out on rotation, it's much easier to remediate. The last thing we want is for a student to get to an end of any healthcare program and discover that these weaknesses are significant and need to be remediated. From the faculty perspective, collecting this formative data along the way allows for continuous improvement of teaching strategies and the curriculum. And I will spend some time talking to you about some of the things that we have done, I think, very creatively with improving the quality of our assessments and really analyzing the data from the individual exams. From an administrative perspective, the ability to document curriculum coverage by mining the data with the use of a tool such as ExamSoft is pretty extensive and brings me joy from an administrative perspective, to be sure. And we'll spend some time talking about that. Some people who have attended some of my workshops before have seen this. Certainly the old curriculum map long ago used to look something like okay, we have a series of courses, we have a series of learning outcomes, we put an X where it's taught, and as long as there's no column without an X, we're good to go. That really is not sufficient anymore. What you want to see is more something like this, where you have your courses and your learning outcomes, and instead of just saying here's where it was taught, we want to say it was taught here, it was tested 25 times, and the student average on that learning outcome is 85.7. Now, this is very, very different than saying, well, we're going to give you a collection of grades on courses, because grades are not assessments. When we're looking at taking test items that are very carefully aligned with the learning outcome and saying we've aligned these 25 questions with that learning outcome, and this is the student achievement on it, that's a very, very different thing. So if we look at this map, for example, you know, if we see learning outcome 3, overall we had 185 questions and the student average was a 65.9, that's telling us an awful lot of information. So a class average of 185 questions at 65.9, we've got to dig deeper. What's going on in that learning outcome? What are we missing? How can we present the material better? Are the questions written well? Are the students studying enough in that data? There's a lot of questions, there's a lot of drivers that could be determining that low average, but it certainly tells us where we need to investigate. So looking at this from a curriculum perspective or your assessment committee perspective, it certainly shows you where to spend some time. Then certainly from an accrediting perspective, they'll also see that you are paying very close attention to, one, you're covering the curriculum, how much are you covering it, and 2, how are the students performing in that area. I want to say one word here about density of coverage. This is a very early snapshot of a map, and where I work now, we have a database of exam questions that's over 10,000. And so over a course of the 3 years that we've been doing this, we have a very large N. But where there is a smaller N, we also look at that very carefully, percentage-wise. There are some learning outcomes that shouldn't be tested as often. And as long as that is planned, that is fine. The density of coverage is intentional. Where there is a low coverage and it wasn't intentional, we didn't realize that was happening, then it allows us to make some corrections along the way. So a lot of data that we gain out of doing this type of curriculum mapping. So that's the outcome, right? That's how we collect all that data, and we use it to start informing decisions at the assessment and the curriculum committee levels. How is it that you go through the process of disaggregating that test data? Well, for those of you who might be new to ExamSoft, we, some people call it tag, we call it code. We code each individual test item or the dimension of a rubric, and I'll talk about that, with an accreditation standard a learning outcome, and a level of Bloom's taxonomy. Some folks I've worked with use Miller's pyramid of assessment. At this St. John Fisher College, we're using Bloom's taxonomy. But so if I ask a question in an exam, I'm going to say, what level of Bloom's is this hitting? And what course learning outcome on my syllabus is it addressing? And what accreditation standard it is addressing? And by the way, it might be addressing 4 of each, I mean, except for Bloom's. It might be addressing multiple learning outcomes. That's fine. Let's take the case of a very rich case study question that might have 3 disease states in it. It might have multiple learning outcomes within your course syllabus. So we can have the coding as rich and thick as we would like it to be. In terms of a rubric, think of every line that you have in a rubric, and we'll talk about this a little bit more. So if you have, let's say you're grading a presentation, a poster presentation, and the student has one component of verbal communication of their poster, another one is the research that went into the poster, and another one is the visual presentation of the poster. Let's say we were only looking at those 3 things, oral, visual, and content. You could tag each one of those dimensions, code those according to the learning outcome that you want, and provide feedback to the student on each of those. And imagine how valuable that is. So instead of telling a student, well, you get a C on that poster presentation, I'd much rather say, you know, your visual presentation was outstanding. Your research was wonderful. You've really got to work on the oral communication. We couldn't hear you. You lacked confidence. Your presentation skills need to be developed. So the student, instead of just getting this one holistic grade, gets this broken down and disaggregated to know where their area for growth really lies. So if you think about that, these are things that we code to, but you could code to anything. And so you'd want to give some thought to what is it that you would code? What is it you want to disaggregate? Anything you want to pull apart and analyze separately and look at the analytics, that's what you want to code. And we'll experiment with some of those. So let's say I'm in the medical world, and the National Board of Medical Examiners has a blueprint for the SLMLE Step 1 exam. Well, what I might do is I might create a coding schema where I number each one of the topics within the USMLE. All right, so behavioral sciences, I'm going to code it as S101, and S1 would be Step 1. Biochemistry, Step 1. 0.02. And by the way, it's always 01 and 02. I learned that the hard way. If you just start with 1, 2, 3, 4, 5, then 11 comes right after 1. So we don't want to do that. We put the zeros in. So this is just an example of something that you might start creating your coding schema if you decide, well, these are the topics I want to collect and disaggregate. So now let's look. If we had an example question, and this is one I pulled off the website on the Step 1 exam, if we have this 32-year-old woman with type 1 diabetes, so I have all this information. I want you to notice, if you think about this, for those of you who would code to in the medical field, you would code this multiple ways. It wouldn't just be one thing. So your density of coverage of your coding is as thick and rich as the question that you ask. And some of the questions, as I mentioned, sometime will have multiple disease states, multiple problems, and it will be coded multiple ways. So if you think about this, you would look at the question and say, well, how many ways do I want to code it? This is probably at the synthesis level. I'm asking for an evaluation of a cause here. And I am not in the medical field myself. I have no idea how to code that, but I'm sure some of you out there would. So you start by creating the question in ExamSoft, and quite frankly, this is the easiest part. Our faculty embraced this because it was so darn easy. Some of them with very huge test banks, cut and pasted. Some of them imported their entire test banks into ExamSoft. But basically, you add a title to your question. you write out the question, you select your answer choices, and you add or remove categories. And adding or remove categories, that's coding. That's where you're going to code the questions right there. The process of coding a question is this simple. Let's say I want to code this question to the renal system. I look at my bank of categories. In this case, we code to systems. So we have S1 cardiovascular, S2 respiratory, S3 gastro, et cetera, et cetera. So if I want to code to renal, all I would have to do is click on this green button for renal, and then it's going to show up as on the list of things I want that it's coded as. Now, if I wanted to code it as synthesis, I click on this button and synthesis is going to show up here. And I'll end up with a whole list of things that it's coded to. If I want to remove it, I just hit on that red button and it would go away. So if you code too thickly and say, it really doesn't match that, just get rid of it, it's gone. So the coding process literally takes minutes because and where we are at our institution, only our faculty code. They know what they're teaching, they know their content. This is generally not a difficult thing for them to do. And once you code it, that's it. You don't have to code it anymore. So if you use that question again and again and again, that coding sticks. So it's a pretty simple process, and I will tell you, faculty have never asked anyone else to do their coding. They wouldn't. Because there's ownership in the questions and certainly ownership in the outcome data. So here's an example from the School of Pharmacy. You'll see I can't fit a lot on the screen, obviously, but if I were to expand this, if this was a live link, I could click on that button where it's a plus, and there are 34 Appendix D topics. Those are our accreditation standards. We must teach those 34 different didactic areas. So we have coded to those. Appendix D is another set of standards. Knowledge application and synthesis, we all know there are 6 levels of Bloom's, but we determined that we cannot accurately code or consistently code to 6 levels of Bloom's. Knowledge and comprehension were just too close for us. Synthesis and evaluation were just too close for us. So what we did is we broke it down into 3, and we code to the 3. I will say just very briefly something about cumulative questions. We came up with a code for cumulative, and that was at the faculty's request. I was really careful about asking for too much coding at the beginning. I said, okay, we're just going to do Bloom's and learning outcomes and accreditation standards. That's it, no more, 3 things, don't want to put too much burden on you. And the faculty came back and said, well, I'd like a cumulative code. So if this is a question that you want the students to see again and again because it's a basic concept, they cannot forget. They simply cannot forget this. And it was taught, let's say, in the fall of the 2nd year. Then you would put it in the bucket from the fall of the 2nd year. So we create these folders for fall of year 1, spring of year 1, fall of year 2, spring of year 2. And if you're looking for a cumulative question, you can pull out of those folders for anything that comes before you. So if you teach in the 1st year, you're pretty limited. But if you teach in the 2nd year, you can pull anything from fall or spring of the 1st year. If you teach in the 3rd year, you can pull anything from the 4 semesters prior to the 3rd year. So, and that's something the faculty asked for so that they could put in a certain percentage of cumulative questions into their exams. So I actually really like that. It shows the students it's not learn it and you're done. It's coming back. So we code to accreditation standards, Bloom's taxonomy, and this faculty requested category. So if I expanded that Appendix B, you're going to see anatomy and physiology, pathology, microbiology, immunology. I mean, all of the things that you would expect to see in the standards. And you can break these down even more. So anatomy and physiology, I can break down into structure and function, molecular aspects, cell physiology, etc. What is nice about this is every time you add a question to a category, it counts it for you. So right now, anatomy and physiology, in this bucket at this time, there were 561 questions dealing with A&P, and of those, 310 were structure and function, 40 were molecular, etc. So you have this running tab of how many questions you have in each area. So now let's just project this out for a minute. You find a student who's really struggling with microbiology, and you give him extra readings to do, you give him extra assignments, you have him maybe watch some podcasts or some Echo 360s, whatever you're using, and then you say, I'm going to test you again in microbiology. Well, that's kind of easy to do now because you create an exam, you open up this microbiology folder where you see 219 questions, and you scroll through it, you look for the questions that performed well, that seemed to you really important, and you make up an exam just of microbiology. And then you can retest that student to see if the steps that he or she took for remediation had an impact. So the possibilities for mining this to retest students is pretty considerable. So I really like this feature a lot. So coding at the course level. Now, I wanted to share with you something one of our faculty did. And again, at first, I didn't even ask them to code at the course level. I said, you know, let's keep it at the program level. But a faculty member came to me and said, you know, I'm teaching top 200 drugs, and there are 9 outcomes in my course, and I really want to know how the students are doing in each of those 9. So he named his outcomes really short so they would fit on a page nicely. So classification, drug indications, counseling adverse effects, brand and generic, etc. So he's got the basic of his learning outcomes for his course there, and he starts piling up. This was very early on in the process. You'll see the numbers are pretty low. So I just took a screenshot of that pretty early on. Well, what he did with this, though, was really interesting because the first semester we did this, he tracked how the students did. Think back to that map I showed you on the curriculum map, right? So we'd say learning outcome 1, the students, let's say, averaged 85, and I asked 36 questions. Well, he's okay with that. Drug indications, they averaged 90, and I asked so many. Well, what he found out was, first of all, the density of coverage of his questions was not what he expected it to be. He thought he was asking more on some of these topics than he actually was. He was favoring some topics without realizing he was favoring them. So that was a pretty interesting thing to do, and so he corrected that for the next semester. The other thing he did is he graphed how the students did on each of these over time, and he found the low points of their progress and then created strategies for dealing with those difficult topics. And then the next year he tracked it again. Obviously we have new students at that point, but he was looking for improvement. And he graphed 3 years layer over layer, and he did demonstrate a couple of things. 1, the density of coverage shifted, and that was pretty easy to do. And 2, he moved the needle. He moved the bar on the student achievement on the learning outcomes. So, and then of course he published. There was great opportunity for the scholarship of teaching and learning. So I really love what he did. He used, and this is, talk about evidence-based medicine. Well, this is evidence-based teaching, and this is evidence-based pedagogy. Very impressive, and this is not difficult to do, but really helpful for the students. So we talked a little bit about Miller's pyramid of assessment, and some of you probably use this. Knows how, shows how, and does. These are the levels of the pyramid. So what you might do with that, if it was me coding it, I put MP 1, 2, 3, and 4. I tend to use coding that is intuitive. So Miller's pyramid, MP. FMLE, you call SMLE1 or S1. We call, for example, Appendix B, I call every topic in there B1, B2, B3. If it's Appendix D, it's D1, D2, D3. Try to keep it really simple and intuitive for the faculty so they know an S is a system and a B is an Appendix B. We use, as I talked about, Bloom's taxonomy. The knowledge and comprehension is so close. What we did, it was pretty interesting. I've done some workshops, but in-house, I put a bunch of questions up in a PowerPoint, and we used Turning Point. And I said, okay, code these to a level of Bloom's taxonomy. And I've done this repeatedly at multiple institutions, and I would have one question coded at 4 different levels of Bloom's taxonomy. I mean, I just couldn't get any consistency. So I did some workshops on how to identify the different levels and gave examples, and then we tried it again. And the best we can do is code pretty consistently at 3 levels. So we use BT1 for Bloom's Taxonomy 1, Bloom's Taxonomy 2, and Bloom's Taxonomy 3. And we're comfortable that we can code pretty consistently for that. Remember, why use all 6 if you can't accurately code 6? Your data isn't any good. I just looked at 3 years worth of data for our students in the P1, P2, and P3 years. And I was very happy to see that we are, in fact, asking an increasing number of application and synthesis questions as the students go through the program. It's not quite the rate I would like it to be at, and so I'm pushing that rate up. We need to introduce synthesis a little bit earlier, but I'm also seeing that the student performance is very much as expected as well. So if we throw application into the first year, they're not performing that well. Second year, they're performing better, and third year, they're performing better still. So you really can disaggregate that data and pull it apart and see what you want to do with your curriculum and your strategies for teaching based on the data that you can pull out of this. So at first with some people, it just sounds like a lot of work. I'm used to giving exams. I give an exam, students take it, they get their grade. Why do I have to deal with all this disaggregating data business and all that? It's driving me nuts. I get that. But what I really found is faculty put a lot of time into creating test items, particularly when we get into cases, but even simple multiple choice questions. If you're writing a good question, that's hard to do. I mean, I've done a lot of workshops on writing good multiple choice questions. It's not an easy thing to do. But if you think about it, you put all this time into creating questions, you give a task, and the student walks away with, I got a B. And they trash all the rest of the data. I mean, I got a B. Instead of looking at that great data that's contained within that B, well, I did great in this and poorly in this, they just take all that hard work you did and collapse it into a single grade. And it's disheartening. It's disheartening for the faculty, and it's pretty much useless for the student because, again, that grade is not an assessment. That grade is not tied to a specific learning outcome. So you think about that and what you might do if instead of putting everything into one grade, you can give them feedback on individual things. Let's look, for example, IP is really big right now. Everybody is working on interprofessional education strategies and how to assess it, how to apply it, how to assess it. But let's say we're looking at, this is interprofessional behaviors that are identified by the IPC and the IPA. So we're looking at this and we see there's communication, there's respect, there's altruism, excellence, accountability, ethics rather. So if we were evaluating someone on these things from observations of their work within a team, and each one of these things were coded separately, you could say to the student, well, you're great on all these things, but your communication skills really need work. Or, your tone doesn't demonstrate respect. You sound a little bit cocky, you sound a little bit arrogant. So you can disaggregate that instead of just saying, here's how you're performing on a team. No, you're performing really well in some areas, but you're struggling in others. And there's so much value in disaggregating that and having feedback to the students that is meaningful. So imagine that you're putting those things into a rubric. I'll tell you, I love the rubric function because you can build it in 10 minutes. You tell ExamSoft, how many columns do I want, how many rows do I want, and poof, there you are. And then you just fill in the blanks. So here's one example. We've got it in 3. We've made it pretty simple. Exemplary, meets standard, and needs attention. So let's say the dimension is verbal language. I put it at the category of application. I gave it an Appendix B level of the professionalism, and B20 forwards might be effective communication. So I've categorized it. I've described what it takes to get up 3 value, a 2 value, and a 1 value, and I've weighted it 10%. Now, when you're building this, if you have 10 dimensions to your rubric, you can switch off the weights. You can make one worth 20%, 30%, whatever you want it to be, and then the values and the score will be calculated. So I know you can't see this, so I put this up there for a reason, though, because I wanted to show you something that it might look like. Don't try to read the small print. That's why I wrote over it. The outcomes go here, the categories go here, the weight goes here. You can have 4 dimensions here, you can have 5, you can do whatever you want on that to measure. It doesn't have to be just a performance assessment that you evaluate on a rubric. You could have them write a SOAP note or a clinical care plan or an essay or a reflection or anything you want them to, a paper. You can develop a rubric for it, grade them on that. You would first pre-release the rubric itself. You send the student, this is how you're going to be evaluated. You'd send the instructions for how to do the assignment, and then you tell them when to upload their submission. So, okay, I want you to have your clinical care plan uploaded by such and such a date because that's when I'm going to begin grading them. So when you start grading them, on the left-hand side of the screen here, I've got the student submission. On the right-hand side of the screen, I've got my rubric, and I just start grading it by pressing on things and grading the rubric accordingly. What is interesting also is on each of these, I can write individual comments. So you did great in this area, you did poorly in this area, great in this area, moderate in this area. So I can write individual comments on these rubrics, which I think is helpful. So, so this is a diagnosis of a medical clinical midterm. And again, it's very easy to do. Don't try to read this again. I'm just trying to give you a visual aid. I don't want to strain your eyes. But imagine I've got this thing on an iPad, right? And we use it for observations of counseling. And we use standardized patients from the University of Rochester. And so we have the standardized patients come in, the students are being observed, the standardized patients are evaluating the students on a rubric. They put in the iPad and they literally hover and click, 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 click. They write their comments in. Some of them don't even like to write, so they press the little microphone icon and they said, you know, I really like the way you explained how to use that inhaler. And it types in the information so the student gets that comment back. Also the nice thing about this is you can have multiple graders. So let's say I want to do this counseling session. I want the SP's grade to be worth 60%. I want an observing faculty's to be worth 30%, and I want students to do a self-evaluation and it's worth 10%. I can split that up and then it'll come up with a nice grade at the end and a report for the students. You can also look at how different graders grade. So if you say, all right, I've got 10 standardized patients and all of the students who go to that 9th one do poorly, you can see how that score is grading versus the other scorers, and then you can do some professional development on the scorers. So that can be useful too. Let me talk a little bit now on some of the other faculty use of the data. So now let's say I'm tracking my course outcomes, right? And it used to be I would say, I'm teaching course outcome 1 and I'm testing it on exams 1 and 2. Etc. I'm using a paper, I'm using a presentation, but I pretty much know I'm teaching all these outcomes and here's how I'm evaluating them. Well, now we're going to do this much like we did with the course map. With the curriculum map, the students, the faculty here do course maps too. So now I have course outcome. Yes, I tested in exam 1 and 2. The student average was 85 and there were 45 items per outcome. So if I'm looking at this type of information, and that's more or less what the faculty member did on that top 200 exam that I was talking to you about before. I'm looking at this, and there are only 19 questions here and 20 here. And if that's appropriate and if that's planned, that's fine. It should be intentional. If it was by accident, not so fine. So you want to look at the data. You want to look, am I satisfied with a 71 on exam 2? For learning outcome 3, not so much. I think I better go back and visit that. Am I satisfied with only 19 test items on outcome 5? If I am, fine. If I'm not, recording the actions to be taken. What I always tell our faculty is you are sitting on a gold mine. Why is everybody bugging you about assessment? Because you've got the goods. You've got everything that everybody from the dean to the provost to the accrediting body, everybody wants to know what you know. And that is, are the students learning? Are the students progressing? So once you know, and then you say, well, I'm not satisfied with this. I'm going to add additional items on this, and you just write it down. I mean, not anything big deal. You just write it down. Next time you teach that course, you're going to make that evidence-based change, and that is the goal that all your assessment committees want, your chairs want, your deans want, everyone wants. So what we've started doing is really exam blueprinting. And my colleague and I just developed this very simple thing for our course coordinators. We might have 6 faculty involved in one exam. So I've just abbreviated this for you. So let's say on one exam, there's the immune system is being taught in microbiology. So Dr. H had 6 lecture hours. We're going to give him 4 questions per lecture hour, and that's how we're divvying up the exam. So Dr. A only had 4 lecture hours, so she gets 16 test items. We want this split pretty much in this. We want to have a little bit of knowledge, more application, and more synthesis because this is in the 3rd year. Now, do the percentages follow exactly? No, but it gives faculty a rough idea. So when the course coordinator is putting together an exam, says, Dr. H, hey, can you give me 24 questions and make sure it's heavy on the synthesis because this is P4? Then that person knows, how many questions they have to come up with. And this is intentional, and it's not haphazard. So everything we do is trying to be intentional and not, okay, I like those questions, so I added them. No, we added them because we really were looking to make sure we have the density of coverage we want and make sure that we are progressing up that levels of Bloom's taxonomy as we move through the program. So what the faculty and the students both get back is this really nice graph at the end of every exam. Looking at each of the outcomes, it'll give the faculty, when they get a report back from an exam, the green diamond here represents the high score, this is the median score, and this is the low score in red. So you'll know on every learning outcome right away. You'll get a quick snapshot right at the end of an exam. Here's the summary, here's how the students did. You'll also get information on the question performance. So if you have multiple choice questions, obviously this is fill in the blanks aren't going to show up in this way, but the multiple choice questions certainly are. So you're going to get the information on the total percent correct in the class, how the upper 27% did, how the lower 27%, the point by serial, discrimination index, and the response frequencies. And the assessment person in me can't let it go without saying, don't put too much weight in the point by serial. To me, a point by serial tells you where to look, but we are not in a norm referenced environment. Medical education is criterion referenced across the board. It is not norm referenced. Nobody wants the physician at the left-hand tail of the bell curve. So we set the criterion. This is what you're supposed to know. If you ask a question that if they don't know the right answer, it's going to kill a patient, then I want 100%. I don't want 75 or 85 or even 95. I want 100%. And if I get 100%, the point by serial is 0. So does that mean I throw the question out? No, it means they got it, and hallelujah, raise your hands. So the point by serial can tell you where to look, but I've had faculty say, I'm throwing out this question because the point by serial was 0.02. I said, well, wait a minute, look at the question. If that was something that you practically beat into the student's head so they would know, you just do a happy dance. Don't get rid of the question. So I can't tell you how many times I've had to drum that question home. What I'm more interested in looking at is the response frequency. This tells me I've got confusion in the class. Students don't know. Yes, most of the students get it right, and most of the upper class got it right. 96% of the top 27% get it right. But there's a lot of confusion there, and there's a whole lot of confusion here, which really concerns me because 36 students chose. Look how many students chose the wrong answer, 48, and 25 chose the right, 49 chose the wrong. So there's confusion there. That's a topic I might want to revisit. So that's how I look at the exam distributions after, and you might want to consider that. I want to make sure I get in some more things, so I apologize for my speed of speech. I usually have more time. Students use the information. I just want to show you, because this was a real case. We had a student who was going across courses, and I keep telling you, a course grade is not an assessment. So we have a student who is, his grade's great. A student, no problem, absolutely, looks like he's got no deficiencies. But when we disaggregated the information, what we found is in one area, he had a 72.5 average. Now, what that area was calculations. Now, nobody wants a pharmacist who can't do calculations. But what was happening is the exam might only have a couple of calculations in it, and he'd get everything else right. So it was masking this deficit that he had, this knowledge deficit. So now we can go and remediate them and pull up those, pull up those calculation questions separately and retest them. But that's a perfect example of how you want to remediate and mitigate a deficit in a student before they go out, and certainly before they go out and take a licensing exam, but much more importantly, before they go out and do calculations for pharmacy medications. So the students are going to get reports much like the faculty are going to get exam reports. The students are going to get reports on how they are doing. So they're going to get something that says, here's my score, here's the class average, that was the percent correct. So this person on understanding Bloom's taxonomy, 73.3, but the class average was 86. That's a little warning light. If it goes below the, if it goes much below this, it's going to turn to red and say, hey, you get a significant deficit here. At our school, we don't give the exams back. We just give the categories back so we can use the test questions again. So we tell the students, here was your score in each of the systems and each of the learning outcomes, but we're not giving the test questions back. Having said that, you could if you wanted to, and you could have the student get a report on their points and their peer points on each of the questions. Again, we don't do this, but you certainly have the capability of doing that. Students can generate their own longitudinal report. We require it. At the mid-semester, we tell the students, generate a report and go see your faculty advisor. So what they're going to do is they're going to tell you, they're going to ask you to reflect on what you can do to improve your weaknesses. So you can't read this, don't bother reading, but the outcomes are listed here. The student score is here, and the peer group score is here. So we have this bar of 85. So anyone who's below the 85, or if the class average is below 85, it's in the yellow, which is warning. The green is above the class average, and the red is below. So this student is showing two red bars. That's where we're going to stop. Now imagine somebody's gone through the whole didactic curriculum and they're preparing for a STEP exam. Where are they going to spend their time studying? They're going to look for the red bars, and they're going to look at their longitudinal report and say, holy cow, I really need to know this stuff. I better put some extra time studying those areas. So what we do is we can create a report for a faculty member and say, okay, you have these 3 advisees. Here's how they're doing on the various areas, cardiovascular, respiratory, gastrointestinal. Now you have an advisee who's getting a 69.3 in gastro. What are you going to suggest? How are you going to discuss that? What readings might you give? What paths might you suggest the students take? Actually, I pulled up a pretty poor description because none of these students are doing stellar. But this is certainly, this advisor has some work to do in talking with the students and motivate them perhaps to work a little harder. but you do have the ability to provide your advisors with this kind of report on their advisees. And you can track this longitudinal data not only at the student level, on the aggregate level, and as we talked about for curriculum mapping, so we know how we're doing on the density of coverage. This is the number of exams that were given, the number of assignments within the exam, or the number of items in the rubric, and the group average. So I track those every semester. So in summary, to use these analytics effectively, we create exam blueprints and we plan for the coverage of the outcomes. We review the exam level results and we reflect on the teaching that's going on and the learning that's going on. We save those exam summaries and create an archive and use those summaries. We share them with the students and we gauge them in the assessment process so they become part of the conversation. We generate longitudinal reports so we can track progress over time. We ask students to reflect on their personal longitudinal reports and plan for their own study and really try to have them take ownership of their learning and their progress. We use the data of evidence of teaching effectiveness when we have our faculty go up for tenure and promotion. They're certainly presenting their scholarship, but they're also presenting how effective they are in the classroom. And our faculty, I work with them a lot on pulling their dossiers together with respect to the teaching and learning aspect and help them generate reports to tell their story of teaching effectiveness. And of course, we use the data for the scholarship of teaching and learning. We use the data to support program effectiveness. We look for our weak points and where we might put more emphasis in the program. The data provided for the students really does help inform study and it guides remediation. The data provided for the faculty documents the coverage of their outcomes, identifies areas of student and cohort weakness, again provides that opportunity for STOL, and provides evidence of teaching effectiveness for dossiers. For the administrators, it gives a really nice map coverage of the curriculum. It documents student performance on curricular goals, and it provides evidence, documents the evidence-based changes. I cannot tell you how important that last one is. Documenting every faculty I know makes changes to their syllabus, to their teaching, to something over the course of the year. 90% of I've met don't document that they do that change. If you just wrote a little note somewhere and said, I changed this because of that, you're documenting an evidence-based change, and the assessment people will do happy dance. So this is really, really important. I'm going to go back again and talk about those external drivers. Remember what we said, that the accreditation standards are calling for increased documentation of assessment data and greater accountability. And the World Federation of Medical Education is looking for that alignment and the formative assessments and assuring the outcomes are assessed. Everything I just talked about directly speaks to these standards. And if you're looking at the standards for a medical education degree, it directly speaks to these 8 and 9 standards for program objectives and outcome data and measurements of assessment and assessing with formal formative feedback. So you're aligning what you're doing, you're creating the story for your robust assessment of student learning and really addressing those external drivers in addition to all of those internal drivers we were just talking about. So with that, I'm going to leave a few minutes for questions, and I'm sorry that I kind of rushed through this, but I put my name there with my Gmail account. I'm presently at St. John Fisher College, but as of May 1st, I'm transitioning to the University of Rochester. Well, I'll be serving as the Assistant Provost for Academic Administration, and I don't want to lose track with people in the downtime in between. So there is my Gmail address. If anyone has questions, I am happy to follow up with you. And with that, Jason, do we have some questions that I can help with?
Yes, thank you so much, Jane and Dr. Souza. We have a few questions. One is, if faculty want to track, for example, mechanism of action in more than one course, Do you recommend creating that tag in every course, or should it be done at a higher level with the different mechanisms delineated?
Well, we do mechanism of action. So if you're, that's a great question. So a mechanism of action is a concept that they're going to have for multiple drugs, for multiple disease, what is the mechanism of action? So I have a broad category for mechanism of action, and I would tag it for the broad category because I want to know that the student understands mechanism of action, not only, let's say, in systems pharmacology, but as they move through therapeutics, and they're if it's a medical student prescribing drugs, that they still retained that information on mechanism of action. So yes, coded at the broad area, but then I probably, if I was teaching it and I attending physicians saying, "Hey, what is this woman doing?" and making me do. So, yeah, and there's always people who are thinking I'm adding to their workload, or the dean or whoever is adding to their workload. And I really respect that because people have been doing this for a long time, doing what they're doing, and they're good at it. So I try to create a balance or suggest there is something that you're going to get out of it. There is value you personally will find in it. And until a faculty member really realizes that there is value, they're not going to buy in. So I really rushed to give some results back to the faculty, and I think that's the best thing you can do for buy-in. If you're starting it in a well-established environment with people are are going to resist, I would start with a few champions, find people who love technology, have them do it, get some data back from them, and say, wow, look at what these people are able to do. And when you see it, when you see what you can give back to the student and what you can give back to yourself, it's pretty darn impressive. So, it's that little uncomfortable transition area. So I guess show results as soon as you possibly can. Whoever's collecting that data and aggregating the data, give it to them as fast as possible. And if you can get administrative help with helping people put their questions in, even better. If you have that capability, make the transition for these big, very, very busy doctors, make it as easy as possible, show them results as early as possible, and that's really the way to create buy-in. What's in it for me?
Excellent, thank you. We have time for one final question. How long did it take to implement this level of integration and use of ExamSoft by the faculty? Did you start with early adopter faculty and slowly roll it out, or do it as an all-in process?
Okay, well, I've worked with faculty at institutions across the country, and most of them do it more progressively, more incrementally than we did it. We did it one semester. We chose our champion faculty who were dying to do this, and we gave them each an iPad and said, hey, let's have fun with assessment. And they just dug their heels in and became the champions and also the tutors, if you will, for the other faculty. Well, we did that for one semester, and then we went 100% all in. Every test, every question, every student, every faculty, every exam in one semester. The reason is we wanted the data. So if you want a full curriculum map, you need 100%. So we were able to do that because the school is only 8 years old. It's not as, we were not so entrenched in a simple way. The other thing is, my God, I never want to see a bubble exam as long as I live. The getting away from the bubbles and the papers was huge. So that goes back to the buy-in too. We were literally creating 4 versions of every exam, labeling A, B, C, D, giving out these bubble sheets, labeling those A, B, C, D, and then monitoring where the students were working, 85 in the class. Make sure an A is next to a B and not next to another A, and blah, 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 blah. Well, now we create this exam, we randomize the questions, we randomize the distractors within the questions. We have 85 students, each of them have a different exam, if you will. And just the headache that goes away from the faculty on that alone was enough to have a lot of them buy in. So we, and not to mention that in the first year, I think we saved enough on toner and paper to almost pay for ExamSoft. I mean, and forget the hours of copying, distributing, and changing every exam. I can't tell you what an aggravation that is. And to have that gone when the faculty experience how much better it is to work in a web-based environment, creating their exams from while having their oil changed or out in a coffee shop or whatever, and just the mechanics of it, we didn't have any trouble. We really, really didn't have any trouble. A well-established, more people who have been working there for a long period of time might have a greater time with transition, which is why some do it incrementally over time. But as soon as you start experiencing those benefits, it catches on. It catches on pretty quickly.
Excellent. Thank you so much, Dr. Souza, for sharing your time and expertise with us today. We greatly appreciate you making this presentation this afternoon.
Thank you. I always have fun doing this.
Great. This concludes today's presentation. At the conclusion of this webinar, you will have an opportunity to participate in the 7-question survey. Remember, this helps us provide relevant content in all of our future presentations. Those who do complete the survey will be entered into a drawing for a $25 gift card to Amazon.com. We would also like to make one more reminder of our upcoming webinar entitled A Pathway to Continuous Improvement in Computer-Based Testing, presented by Dr. Veronica Powell-Shuford of the Virginia Commonwealth University College of Pharmacy. This presentation is scheduled for March 31st, 2015 at 3 p.m. Eastern Time. We would like to conclude today's broadcast. Thank you so much, everyone, for your time and attendance today. We appreciate those who ask questions. If you do have additional questions, please do feel free to email Dr. Souza, and you may also email info@examsoft.com. Have a great afternoon, everyone, and thank you.
Thank you again. Bye-bye.